There we go. Okay.
I think we're ready for you, Dr. Bennett, when you're ready.
Oh, great. Hi, everyone. All right, I'm already sharing my screen, so great. Hi, so I don't know who in this group I've met in person or online before. So I think I'll begin by introducing myself. My name is Melanie Bennett, and I am a professor at the University of Maryland School of Medicine in Baltimore. And I'm also a psychologist by profession, and I'm credentialed at the University of Maryland Medical Center. And three and a half years ago now, I came up with an idea for a research project. And we applied for funding and got the funding and are now doing the research project. And at the time, I wanted to try and do this project not only in Baltimore, where I sit and I'm used to doing research, but with another hospital system or another provider in our hospital system that was outside of Baltimore. And so I met Dr. Lewis, basically by just saying, who's the chair of psychiatry somewhere else, not in Baltimore? And he was recommended to me. And he said, sure, you bring us funding and we would be happy to be a site. So we've been doing this project now, which I'm going to tell you about for a little bit of time. I'll show you the timeline. And so Caroline Silva, who's there with you, and I worked together on this, and she said that she thought it would be good to check back in with everybody and give a reminder of what the project is, that there are some new people who didn't know what was going on or why we wanted to do this or anything like that. So that's what brought me here. I'm sorry I'm not there in person. My goal was to be there in person, but I do part of my job at the VA, and Tuesdays is my VA day, and it's a little bit harder to take time off at the VA and be somewhere else or whatever. So when Caroline, Adam, when you offered it could be remote, that worked for me. Okay, so I want to give an overview of the project for those of you who didn't catch it one of the other times. And then I'm most excited to just tell you what's going on now, because we're now about halfway through the project and things have been happening, even though you might not even know that. So, and then I would love to hear from you all. Okay, so the title of this project, External Facilitation to Increase Prescribing of Alcohol Use Disorder Medications in the Psychiatric Setting. So I'll tell you a little bit about what got me interested in that, but it's funded by the National Institute on Alcohol Abuse and Alcoholism, and it's funded for 3 years. It's this special kind of mechanism where they say, we think this is a good idea, but you don't really know what you're doing. So take a couple years and work some stuff out and collect some pilot data, figure out how you would do this if you were going to do it, do a larger trial. And that made a lot of sense because that's exactly my situation with this topic area. So we're developing an implementation intervention at 3 sites. You can see that Klein is one of the sites. And then 2 of the sites are community psychiatry outpatient programs here in Baltimore. And so there's a big group of us. You should recognize Caroline because she's sitting there, and me because I'm here. And the rest of the people, I'm going to tell you about Max and Melissa in a minute. The rest of the people are experts either in, developing medications. Clay Brown is our biostatistician. Emily and Brian make sure things actually happen. They're coordinating and doing interviews and things like that. These are our 3 sites. Okay, so as I mentioned, I'm a psychologist by training, and I'm a psychiatric services researcher. What that means is I spend my time aggravated that people with mental illness don't get treatments that work. And so what I try and do in my research is to figure out how to get people with mental illness treatments that work. Now, sometimes there are no treatments that work for something, and then I might be inspired to try to make something that works and then test it, see if it really works. But in most of the time, there are treatments that work, right? This is a group of people who doesn't often get what works. And, that's because they have a lot of other things going on. Mental illness is complicated. So I like to think about ways to understand what treatments work and bring them to the spot where the patients already are. Okay, that way people come to one stop, they get a bunch of different things, they don't have to go to a bunch of different places. And that's not always possible, but I feel like many, many times it is possible. So part of my big area of interest is comorbidity, people with mental illness and substance use disorders. So I do a lot of work in helping people quit smoking, and why, when there are so many ways people can quit smoking, if you happen to have a mental illness and you quit smoking, it's very hard for you to get connected with treatments that work. Well, with alcohol, it's the same thing. There are ways to help people with their drinking, and a lot of times patients with mental illness are referred to specialty care, right, to specialty alcohol or drug abuse treatment. And that's really hard because it means another place you have to go and another set of people, and then those people have to talk to your psychiatry team. And it's just a lot, some added steps. So nothing on this slide is going to surprise you. Lots of people with major mental illness, we're talking things like psychotic disorders or affective disorders that have a lot of functional impairment associated with them. Having an alcohol use disorder is pretty common. What you might not know is that there are medications that can help a lot of people with alcohol problems. And they're really good for all people. It doesn't matter if you have a mental illness, these medications can help you too. But these medications are not widely utilized across all sorts of people, not just people with mental illness. So something to keep in mind, if you work with people or you know people who have an alcohol problem, we're really in a nice moment where there are medications that can help. And sometimes people don't want or find it trying to think about going to therapy. And so opening with a medicine for a lot of people could be a nice first step because it feels easier and more manageable. Okay, so I want to understand how we can make these medications more available to people with mental illness. We actually looked at the data across the University of Maryland medical system to confirm, maybe we were actually really good at prescribing these medications, but we're not, don't worry. So we looked at a sample of over 10,000 people who had co-occurring alcohol use disorder and a major mental illness. And you see that about 7.2% had been prescribed any of those 3 FDA-approved medications in the last 3 years. So we felt like we should be able to do better than 7.2%. Okay, so that led me to think, well, where do these patients normally receive their care? And that is in places like psychiatry and Klein, right? There are different sorts of settings, outpatient psychiatry and a crisis center. But, at Klein, you see a lot of people with mental illness. And I'm guessing co-occurring alcohol use disorder is not that uncommon. I'm sure you see plenty of people with alcohol use disorder. Another reason why psychiatry is a good place to talk about drinking is because people's drinking often impacts their mental illness. So we're talking about it anyway. We're often doing therapeutic interventions, we're often using motivational interviewing and skills-based approaches and trying to help people learn new coping skills and trying to shore up their motivation. So we're already talking about it anyway, which is great. We're also in psychiatry and crisis pretty, I don't know, used to comorbidity, like somebody coming in and having more than one issue that they need help with is not a surprise to us, where in other, some other places you might get care, you're being seen for, one thing at a time. There's a lot less stigma around that comorbidity in mental health settings. So we did a survey in here down in Baltimore, our outpatient psychiatry programs, and we said, what do you know about these medications? What do you need to know? What keeps you from telling people about them? And we had two sort of separate bundles of barriers. One was from prescribers. Prescribers who were primarily working in psychiatric treatment settings felt that they knew plenty about the medications, but thought that they should be prescribed by, people who that was the first, like their bread and butter. The first thing that they did was prescribe medications for substance use disorders. Then we had non-prescribing clinicians and staff who said, well, I don't really know enough about these medicines to talk to patients about them and weigh in on whether they should take them or not. So our prescribers felt like they had enough knowledge, but just not enough experience. And our non-prescribers said, I need to start from the beginning. I don't even have enough knowledge to talk about this with patients. One thing I was worried about, but that actually didn't happen, I thought, well, maybe people just don't think you should use medicines for alcohol use disorder. And, as a psychologist, I am therapy all day. But when a medication can help, I think that is a great tool that some people can make use of, and especially when people are reluctant to engage in therapy and they're just not ready to talk about all that you need to talk about to change a health behavior. So I was thrilled to see that, at least from this survey, people were not opposed to a medication as a tool in the treatment of alcohol use disorder. Okay, so then I wondered, well, these medicines are around. They're not terribly new. So maybe there's something to be said for the non-prescribers, providing the education and tools that they need to be able to talk to patients about the medicines. And for the prescribers, perhaps it's, letting them know that you can prescribe an alcohol use disorder medicine anywhere. It doesn't have to be in an addiction setting. If the person's in an addiction setting, terrific. But if you're seeing that person monthly and you're prescribing antipsychotic medications or medications for depression or anxiety or any number of things, there's no reason why you can't add this to the sorts of things that you prescribe. So we decided to try to study what's called implementation facilitation. How do we work with clinics to understand what they need, their own barriers, and working to overcome those barriers? So I'm used to doing work where I go in and I tell the clinics, here's what you need to do. And that's not such a great way to be, as it turns out. But with this challenge, it's really not the right way to be, because I have no idea what the Carruthers Clinic or what the Klein Family Crisis Center or what our other clinic, the Fayette Clinic, needs to do. I mean, I need to understand the barriers, and then I can make tons of suggestions. And the clinic has to figure out, okay, if this is our goal, here are all the tools that Melanie and her team and Caroline and the team are giving us. how do we want to use them? How do we work them into our everyday routines and our workflows? So that's what implementation facilitation does. It sort of bridges a clinical program that is set up to run in a certain way with somebody saying, okay, well, there's an evidence-based practice, and here are some ways that you can take up that evidence-based practice. So implementation facilitation can include lots of different things. Sort of the hallmark is an external facilitator who gets to know each clinic and works with the clinic to understand them, right? And that's the role that Caroline fills. So she works with the clinics and probably asks a lot of questions and likes to be around and see how things go and asks to come to meetings. And all of that is to learn how you work and what, from now we're starting to get a picture so we can make some suggestions. But other implementation activities are providing training and education so that both to staff so that you would know, for example, what the medications are and what they do, and to patients. Patients came in and said, I hear there's a medicine for alcohol problems, and you may have noticed that I'm drinking a lot. Maybe I should try a medicine. This slide, you're going to get the slides. This is a pretty cool paper where they did a similar implementation facilitation approach. It's in tobacco, but they did it in a community mental health care setting. So if you want to read a good paper, I recommend it. So we decided that this seemed like a good approach. We have a clinical intervention that's evidence-based. We have programs that see people with alcohol use disorder. And in implementation facilitation, we're trying to work with clinics to see their barriers to uptake of an evidence-based practice and helping them overcome them. So we have 3 aims to the study. We've pretty much finished aim 1, although if after hearing this today, you would like to talk with Caroline about your views on your clinic or your role in the clinic, the barriers you experience to educating people about alcohol use medications or prescribing them if you're a prescriber, that would be amazing. We'd love to hear from you. And then we spent some time developing a bunch of different activities. So we have some training modules, we have patient-facing educational handouts. We're developing, I'm going to show you a little more. We've developed some reports in Epic that will help programs track. Okay, here are our patients with alcohol use disorder. Here are the ones we've prescribed alcohol medicines for. Why are there some that aren't? And let's talk about those patients. One thing that's already happened at your program is identifying a champion. So a champion is somebody at each program that thinks this is interesting or has some interest in either helping patients, working with alcohol use disorder, or likes the idea of working to help the clinic make better use of an evidence-based practice. So more to come on your champion. So we've done most of aim 1, and we're squarely in aim 2, which is doing all the stuff, offering trainings, offering educational moments, showing you the reports, helping you figure out how you might use those reports in your practice, making available regular consultation. One thing that prescribers have told us in the interviews is, every once in a while there's a patient, I'm just not sure if any of these medications are a good idea, if they're going to interact with the medications they're already taking, or this particular medical problem. So we have somebody, or 2 people that prescribers can consult with. And then our final aim will be probably next year at this time. We will look at prescription data in Epic for the 3 clinics that are part of this, and we will see if prescribing rates went up. So we can pull data from before the project started, and we can pull data from after the project happened. And if it was 7.2 before, like I had on that slide, and now it's 10.5, we can, at those clinics, we will attribute any increase to the fact that the clinics have been working on this and paying close attention. I don't know that we're going to do 3B. We don't really have a good way to document if a non-prescribing clinician or staff person talks to a patient about alcohol medicine. You know, we've been talking about you drinking a bunch here. I recently learned that there are some medications you might find helpful. I'd love to tell you about them. And then if you're interested, we could, make sure that when you have your next prescriber appointment, they can talk to you more about it. Like that would go in a progress note, is what we're told. And we just haven't figured out a way to kind of yank that out of the EPIC data. So more to come on that. I don't know that we'll actually do that. We might do it for a subset of patients where we have permission to look at EPIC progress notes. So we could have a team where we pick 10 patients and we just read progress notes and we'll see what. Okay, so that is the overview of the study. I want to tell you a little bit about what's going on now, and then I will just stop. And I'd love to hear from you or any questions or just comments or what you think. Okay, so we have a lot of things in progress. Some of them you will have heard of or participated in, and some of them you won't, and that's okay. But our job is to make sure you know about everything that's going on, and we hope that you participate, but that's up to you. So you may have heard that you have a champion amongst you who is working with Caroline. So that is Peggy. And she and Caroline meet and talk pretty regularly, trying to figure out the best ways to introduce implementation activities to the team. So you're already ahead of the game by having a great champion involved. You may be on our email list. We have an email newsletter. And what this does, it's less about its own implementation activity, but it's just a way to keep everybody up to date on what's going on. So these are just screenshots of one of the more recent ones. And you'll see we list like what's going on. There's this presentation happening. If you missed it, you can click and we have it posted somewhere. We usually do a little medication moment, again, because our job is to help you learn about these medicines. So in the newsletter is just another venue where we can put a few little nuggets of information, and you can always go back to it. So if you are not on the email list, I would encourage you to add your name and give it to Caroline. She will make sure. And if you get the newsletter and you're like, I really don't want this, you can always decline it for the future. We have done and continue to do virtual and in-person trainings, and then we're recording them. And we've spent a lot of time talking about fancy pants ways to have a portal and something where all the trainings are. And we decided to go lower tech because the fancy ways are hard and expensive. So we have a YouTube channel where we're putting up all the stuff and you can access it. Either if you had, you missed a detail when you heard it, or you weren't able to make it when it was live, or make it when it was virtual. So we have several things up already. If I had to plug any of them, I would plug the first one, the medications for AUD sort of 101. And that is one of our investigators, Dan Roche. And this is what he does for a living. He knows medications. And one thing I think he's done nicely in the training is he's talking about it in like a way that non-prescribers can really get a lot out of it. And I take that to heart as a non-prescriber. Sometimes if you're too in the medicine of it, I don't get it. But we have a couple there. We just put up motivational interviewing strategies to talk about drinking. We heard in some of our interviews, and we've, Caroline's been to a lot of the clinics, and I've been to a lot of them too. We've heard people say, people come to this program for mental health treatment. And so we don't really want to open with alcohol because that can really be off-putting to some people. And we want people to come back, which I 100% agree with. So we were asked, like, what are some ways to bring up drinking since we are not in an alcohol specific program? So I did maybe 50 minutes, but you can like scooch through it, and on using a few motivational interviewing strategies, things that you're doing all the time, reflections, open questions, nothing very complex. So check it out. Also, as you digest all this information, if there were things that you thought, well, I really need to know X, or I actually don't talk to people very much about drinking, or I would really like to know how to do this, and you just tell us, and we will, if I don't know how to talk to you about it, we will find somebody who will come live or do a virtual, or we will record it and put it up on YouTube. I'm going to skip to this. So another thing we were asked is we had a lot of clinics tell us we don't really screen for drink. Like, we ask people about their drinking, and sometimes they share it and sometimes they don't. But we don't have a good way that we gather, brief but standardized screening information. So we have spent a good number of months trying to get a tool called the audit into Epic. Now, I believe that at Klein, you have always had the audit in Epic, which is amazing. That puts you years and years ahead of your colleagues in Baltimore who did not, they had actually, a brief audit, the audit C, which was 3 items, but you have always had the 10-item audit, which is the more comprehensive audit. There's also something called the cage, and down here, people were using the cage a lot. We are recommending the 10-item audit. What that does is it gives you 3 items about, it combines the 3 consumption items. Are you drinking? How much are you drinking? First 3, and then the 7 problem items, which you need to start considering a diagnosis. You need to know if they're having problems because of their drinking. So you already have it in Epic, so you don't need to actually see it or locate it on a piece of paper. But if you ever wanted to, you now have a link to do that. But one of the biggest things that took the most time is to get access to the audit in Epic for the people in Baltimore, the providers of Baltimore. So we have been able to do that. And then we have made a recommendation about doing the audit. I believe that you all do it with some frequency. So again, you're way ahead. But if you individually in your practice haven't been using the audit, check it out. It's there. It's quick. I feel like the questions are, easy. Like, I don't think if you're doing it, for example, you're meeting somebody for the first time and you're asking them a lot of questions anyway. These questions I don't think would make somebody go, oh my God, you're asking me about my drinking. I can't believe it, and make people storm out. And then we have, the scoring and how you might think about what to do with scores. So people who are low risk, I generally say something like, you have scored really low on our alcohol screening measure, good for you. But alcohol is something that we could talk about. So if you're ever interested in learning more about your drinking or whatever, or you notice it's ratcheting up a little bit, please let me know. We can always talk about it. it's these groups, usually that middle group where I'm not, and I will say things like, I think we want to keep an eye on that. And maybe in the, a future meeting, we can repeat this screening and talk a little bit more about your drinking. And those who are in the high risk range with possible AUD, I'm more, really talking with them about, we've talked here about your drinking and you answered some questions, and I really want to now follow that up with some more detailed questions to see what's going on with your drinking, and if there's any way that me or we at this clinic can help you with that. Okay, so that's screening, which you can be doing. We have figured out how to get reports from Epic. This is something I think Caroline is on the cusp of working with Peggy, and so with you all, to design a report. But in Epic, it is possible to generate a list of the patients in your clinic who have an AUD diagnosis, which means that when you want to be sure to put that AUD diagnosis I think it's in the problem list. You can get a list of those patients, and then by name, who is prescribed an alcohol medicine and who's not, which can be really handy because sometimes it's hard to keep track of everybody at one time. This is just an example. I didn't want to put an example that had patients' names in it in the slide deck, but you can also find out by medicine how many people in your clinic are taking that medicine. So we're working out different views on these reports, and Caroline will work with you all to design a report that's right for you. It can have more than this. We have one clinic who is toying with adding some other pieces of information. I mean, as long as it's in Epic, we can pull it into a report. The goal of a report like that is that somebody would look at it from time to time and talk about it. So it's called an audit and feedback when you pull the data and you use it to sort of say to yourself, oh, okay, there's 20 people with alcohol use disorder. 7 of them have been prescribed an alcohol medicine or have a rule out. So let's talk about these other 13, maybe one at a time, spread them across a couple team meetings, however you feel is the best way to do it, to figure out, if these medications are right for those people. We also have diagnostic and medication consultation. So Max and Melissa are 2 psychiatrists, and they do a lot of prescribing of these medicines within community mental health. And so they can come to you. You can have a phone call. They're in it for whether you want a longer consultation or you just want a phone number to call and say, hey, Max, I have this patient, can I do it? Or here's what I'm worried about. And then the last thing that's coming aboard is that we're hoping to learn a lot from this, both about what barriers clinics face, what your teams find more or less useful, so that we can then go on and do a bigger study with more clinics. So we're also have a couple of papers and I guess projects that sub-projects that we're working on. And then our data will generate at least an outcome paper and an interview, results of the interviews that we did paper. So if anybody wants to be involved in any of that, we are happy to have people involved. You can go over the ways to participate and be a co-author. I think that what happens is people who don't do research for their job as their primary job think they have to do everything in order to be an author, but you really don't. I work with people who primarily spend most of their work time as clinicians. I'm like, sometimes there's just an idea that I need input on because I don't understand how to describe it, or I'm thinking of writing something this way, but it makes sense to me, but of course I don't work in a clinic. So it's just being a sounding board is a very important job when we're thinking about how research applies in the real world. So if any of that seems interesting, I'd love to hear from you. I know that at least the faculty, people who are hired as faculty, have to show that they have scholarly output. And that can be really hard when your job is to help patients. So when I go up and I get reviewed, nobody expects me to help patients, right? Because my job is to have scholarly output. But for faculty who help patients, they are also expected to do my job and their job, which seems ridiculous. So anyway, this is a great opportunity to, we'd love to have you. So maybe I'll pause there. That's a lot. Thank you for listening. But I hope what you took from this is we're doing this project to try and get these medications used more with this high-risk group. But we don't know how to do it without you telling us what are the best ways to do it. I'm happy for questions or thoughts, or I don't know if there's anybody talking in the big room. I can't hear.
Me?
Ah, now I can, yes.
Ask them for it. Just with data, and we as prescribers are presenting our patients to use what we can do for them. I think I'm understanding that. Did you hear the question, Melanie?
You're kind of going in and out. What I heard was, is this a project where you would send a patient to our team to learn
Yes.
about medications? No.
Okay.
This is a project where we want to work with you so that you feel you have the knowledge to talk to your own patient. Because you and the patient are the two main people working together. So it's more about working with prescribers and clinicians and clinics and teams to think about, why is this something that you're not prescribing if you're a prescriber? Or why is this something you don't talk a lot about? And how can we help you feel better able to do that?
And if I could just share some of the information that we got from prescribers through the interviews was, in some cases, prescribers, therapists aren't encountering this very often, but on occasion they are. And as a prescriber, sometimes because it's not something you're prescribing on a more regular basis, like you might be prescribing, for example, an antidepressant or something like that, that sometimes the needing consultation with somebody that does prescribe this more frequently. It's not that you can't, it's not that the prescriber can't prescribe it, it's just they don't do it as frequently. And when we were doing some of the interviews with prescribers, we heard multiple times, I have to go look it up because, I remember learning about it, but I don't do it very often. So as a result of having this project, and two clinician experts who do prescribe, you have access to them if there's potentially somebody that might benefit, but you're not sure. You can talk it over with one of our clinician experts and maybe develop a plan for how to introduce it, or if the patient might be interested. And surprisingly, some of the patient interviews actually revealed that patients were interested in it, they just didn't know about it. And so sometimes they raised it with their, they sometimes would raise it with their therapist, sometimes they would raise it with their prescriber. And so that's the whole additional kind of aspect what Dr. Bennett is talking about, is kind of like the collaboration amongst prescribers, non-prescribers, and patients to hopefully facilitate people getting prescribed this more frequently if they would benefit, because there's multiple things you have to consider, obviously, with each individual case, because these are complicated cases anytime somebody is dealing with major mental illness. Does that help?
So it's more like a resource.
is, there are maybe, I can't remember how many are not prescribed, but the pink bar on her slide, that is the people that are not being prescribed. And then the shorter bars are people that are being prescribed. So theoretically, there's more patients that would potentially benefit, but they aren't getting prescribed the medication. And I can't remember what the percentages are, Dr. Bennett, I don't know. I know Dr. Roche will say, has numbers in his mind of how many people will potentially benefit and how many are actually being prescribed. And he does go into that in his presentation, which is on our YouTube channel. So, and I'll be giving everybody access.
I don't know if someone else was talking. I can just speak for myself. Sorry, I'm in my office, but I can read better when I'm closer to the words. So I can read it better when it's on my screen. Anyway, so I'm a psychiatrist, but anyway, for myself, I mean, I think the meds used are great. I would have no problem prescribing them. The issue is I don't personally feel that there's the support available. Like we used to have peer counselors, and then we don't have peer counselors, and I don't like prescribing a medication because I think sometimes the patients only use that. You know, like, oh, I'll just use antabuse if you know, like as their only method, just so they can be dry, not really so that they can get engaged in any type of treatment program. I mean, if someone comes to me, they're at Ashley, which is right next door or somewhere, and they want to be on naltrexone or antabuse, I have no problem prescribing it for them. But I think that's usually my hesitation, you know, but I'll screen for alcohol use disorders, but I feel like it lulls people into a false sense of security where like, just go on this medicine and it'll help, you know, kind of keep you. I have patients who are on it, but they still drink because they're not in any type of treatment. So that, I mean, that's for myself. I can't speak for anyone else, but I know that for me
Yeah.
is my issue is I don't personally feel like, I mean, some patients, I have patients who would benefit, but like, I don't have the bandwidth myself to, you know, get them to where they need to go. And so
Oh.
that's one of the reasons why I probably don't prescribe it.
Yeah. And I think that is a really important consideration. So, a medicine is really good when you take it. So these are medicines that you have to take in order for them to work. And so what you're bringing up is very important. In an ideal world, you're working with somebody around support or therapy to improve the motivation to want to not drink. And the medication is a tool in that journey, right? It's not the starting and the end point. And I could not agree more as a person who that's what I like to do. I like to talk to people and help them maintain behavior change. And my lens is always, let's get to a point where you learn what you need to learn so that, you know, you're living your life eventually without a medicine and without drinking, or, you know, drinking moderately, or how, you know, whatever your goal is. So I agree 100%. Where I think that sometimes lately, it's taken me a little while, but lately I've become more flexible around sort of what has to come first, right? So I think either therapy and medicine should start at the same time, or you work on some therapy or with support to like gear up. So you're sort of starting that behavior change mental process, and then the medication can help with that. But lately, I've changed my mind in that I don't mind if people decide, I think a better place for me to start would be starting with the medicine and seeing like, if I take that medicine, does it really help me not drink? I can be cool with that. So if somebody's willing to try something and then we can talk about how did that work for you, or what did you like about that, or what didn't you like so much about that, or how could you see that helping you with your goal of reducing your drinking, moderate drinking, no drinking, taking a vacation from drink, whatever the goal is. So I don't know if that helps you think about it in, any, it doesn't sound like it's in any new kind of way, but just lately I've changed my mind on medicine in all sorts of types of medicines. So I don't have personal experience, but I see what's going on around the GLPs and weight loss medication. That people who really had a tough time, this really helps them. Or I spend a lot of time talking about tobacco treatment. And there are some really good medicines that help people quit smoking. And nobody knows about them because we're very used to saying the solution is that you stop smoking. And so then I go and I tell people, well, we could arrange for this and you could use this medicine for, 8 weeks, 3 months, we see how it's going. And they're like, really? I don't even have to stop smoking in order to use a medicine to stop smoking? So I think I feel good about starting with a medicine if it can sort of jumpstart that motivational oomph. But I get it. I don't disagree with you.
It's Audrey. I'm Audrey, a nurse practitioner here at Aberdeen. My question was, there are times we do the screening, especially an intake, and then if someone comes in with alcohol issues that's actually impacting their relationships and sometimes their work, you offer a treatment. It's like, I think I'm okay. How do you overcome that? So
Right.
you've done the motivational interview. You identify for them how this is truly impacting their life, and they're just reluctant to try.
Yes. So that's exactly what so look over to our YouTube channel and you can hear me talk about it for 45 minutes. But you bring up a great point. Any kind alcohol, like many other health behaviors, is hard to change, and people are not always ready, right? We're ready. We're totally ready for somebody else to change their drinking. And we can see it in a way that sometimes people do not see or are not ready to see. I generally want to keep the conversation open. And it may be that the way, some clinics are set up, you don't know that you're going to have a weekly visit or 2 times a month or whatever. It's more people come in when they come in. But I try and keep it something that I bring up every time. And using some of MI strategies, I, somehow communicate that we see it differently. That you are, not seeing that many impacts from your drinking. Tell me what tell me what you do. But you're not really seeing that it's affecting your life. And it's interesting because when I talk with you, I get a little bit of a different feeling that maybe there are some ways, maybe not giant ways, but, some ways that are creeping into your life that say to me that this is starting to impact things in different ways. So that's kind of where I might start. We see this differently. I want to keep it on our agenda so that we can start to share how we're seeing it. And then I'm hoping that over time, as I start sharing, tell me how your alcohol, you were saying about you were working and then it got sort of hard to get to work. And I'm wondering if drinking or alcohol was even in the teeniest way, like related to. Tell me about that. And you're hoping for keeping it on the agenda, talking about it in a compassionate and curious manner. If somebody's really clearly got, they're really in, you see it, then I will do more. What's the word I'm looking for? Like more right up front. I often preface that with, I want to talk a little bit about something and I want to be really honest. So I want to tell you what I'm seeing, and then I will pause. And I want you to tell me how that landed with you. because I think we might disagree on this. So we did some screening about your drinking, and you've talked a little bit about your drinking, and you don't seem terribly worried about your drinking, and I feel pretty worried about your drinking. So I want to tell you about what worries me, and then I want to pause, and I want to hear your reaction to that. And my goal here is not to, make you feel bad. I talk to plenty of people about all different sorts of health things that we don't see eye to eye. So I'm ready for you to not agree with me, but it's something that's on my mind, and I really, so you're and then you're back, and then you're back a little, but it's a process. You're exactly right. It's very few and far between the person that says, hey, I think I'm ready for an alcohol medicine.
Yeah, very few. Okay, thank you.
Sure. So this is great. And the goal of the project is to help give you what you need to try something out, or think about something, try prescribing or try talking to somebody. So now that you know all this, think about how the project can help you, help your team, and help your clinic or your location. You want us to come, you want us to talk, you want patient-facing materials, whatever the case. We are here. Right, Caroline?
Absolutely, and I've shared patient-facing materials with both Klein and with the
Thank you, bye.
Behavioral Health Pavilion as well. So thanks for your time.
Yes, thank you all. It was great to meet you. And Adam for setting it up. Everything works. You're a genius.
Very welcome, Dr. Bennett.
Thanks so much. Thank
Bye.
you. Thanks, Melanie. Recordings.